My name is Emily Hewlett. I'm a health policy analyst at the OECD, and I've been here today talking about our recently published book on mental health called Making Mental Health Count. Today I was speaking about making mental health count in Europe and in the OECD, and about the social and economic costs of mental ill health. Oui, bonjour. Merci beaucoup pour cette introduction et cette invitation. C'est bien la première fois que ce livre soit présenté en France. Et alors je suis très très heureuse de pouvoir transmettre les idées principales de ce livre. Et j'espère discuter un peu avec vous, savoir si les idées vous correspondent bien, si c'est bien ce que vous voyez ici en France, si vous avez des critiques, des recommandations, des idées différentes. Moi je suis, oui, comme présenté, moi je m'appelle Emily Hewlett, je travaille à l'OCDE. Comme vous avez peut-être compris, je ne suis pas française, je suis anglaise. Et là j'ai préparé tous mes slides en anglais, donc au lieu de vous torturer avec mon accent anglais pendant 45 minutes, je vais plutôt faire en anglais. Par contre, si à tout moment il y a des choses que vous ne comprenez pas, il vous faut une traduction, n'hésitez pas. Et si à la fin vous avez des questions, n'hésitez pas à les poser en français, je vais faire mon maximum de répondre. Mais là je vais transférer, I will switch into English and maybe slow down a bit so that I take everyone with me. As was indicated in the introduction, this is a book that we've done at the OECD. It came out in July, and the book really tries to give a sense of the state of mental health, the organization of mental health systems, and the major challenges that face systems today, as well as try to give some recommendations about how to go about addressing these challenges, or even just which are the most important challenges. Where does most of the energy need to be focused? In order to do that, I've split it into 4 rough parts. I'm going to start just by introducing the OECD for anybody who doesn't know, so that you see where we're coming from and why we draw some of the conclusions we do, and the way that we go about doing the work that we do. Then I'm going to give a rough overview of the similarities and the differences in the shape of the systems, so the way that mental health care is delivered and organized in European and in OECD mental health systems. And then move on to talking about the state of mental health. And even in describing the system, I think some of the problems and the challenges that face mental health systems will have come up. But really to draw out some of the clear economic and social costs and the associated challenges that we've seen while doing this work. Finally, I'm going to briefly go through some of the recommendations that have come out of this book. It's like a whistle-stop tour through a 250-page book, so I'm saving you all a lot of time by summarizing it in a much shorter period. But if you have further questions, happy to discuss any of the elements in more detail. So firstly, the OECD, just so you all know who I'm talking about when I say the OECD countries. The countries in dark blue are the OECD countries. The lighter blue countries are the partner countries who are not OECD members, but we have good working relationships with them. So that includes Europe, North America, some South American countries, Australia, New Zealand, Korea, Japan. And it is an international governmental organization, so we're funded by governments, we're run by governments, our missions come from governments and ministries, founded in 1961. It's a forum for governments primarily to work together and share challenges, ideas, and also best practice. It's one of the world's largest and most reliable, we think, sources of comparable statistical, economic, and social data. And our mission statement is better policies for better lives. So the role of the OECD Secretariat, of which I am part, is to help contribute analysis and data and ideas about what should go into these policies and politics, what we need to do in order to create and form these better policies which are implemented in our member countries. The OECD work on health obviously reflects that. Part of our major role is to provide comparable data on health system and to apply economic analysis to health policies. We advise policymakers, stakeholders and citizens on how to respond to demands for more and better healthcare. Increasingly, that also means more and better healthcare, but not for any greater cost. As well as the work on mental health, we work on topics like health spending and financing, quality of care, the economics of prevention, health workforce, and long-term care. And in terms of the OECD work on mental health, there's been a mental health element to the work that the OECD's been doing for much longer than this project has existed. That includes some of the data collection work we do. One of the oldest bits of data that we collect and present is data on mortality from suicide. I've put this up from 2011, which is from our flagship statistical publication, Health at a Glance, which the European version, I've highlighted France over there. We also collect data on hospital beds, so this is part of the core data that we systematically collect, so that includes psychiatric beds, and some information on workforce, so for the mental health field that includes number of psychiatrists. And again, I highlighted France. But really, the OECD Health Committee, a few years ago in 2010, were aware of the work we were doing, were aware of the information we did have, but there was a feeling that the information that we had available didn't really say enough. I mean, the psychiatric bed numbers, the number of psychiatrists, no offense, doesn't say enough about the true state of mental health systems. The committee asked us to do some more work and some more profound work on thinking about really how mental health systems looked, as well as what the real challenges were facing them. So that's what we did. It took us 3 and a bit years, but in 2014 we published this book here, which is called Making Mental Health Count, and it focuses on understanding the social and the economic costs of neglecting mental ill health, which we're saying is what's happening, and also in coming up with some recommendations to try and deal with that. So as a starting point, we looked at the shape of the mental health systems. And really what we saw with mental health systems, which wasn't the same perhaps as health systems in the OECD, were some really significant differences in the way that countries organize the provision of care. So when we talk about the OECD countries, we're talking about a set of countries which are really generally quite similar. They've got a similar level of economic development, they have similar approaches delivering their healthcare. We hope they're all moving towards similar improvements in performance and quality in delivering their healthcare. But we saw, when we looked at mental health care provision, that there were really quite significant differences in the way that care is organized, even amongst this quite similar group of countries. So starting with the basic OECD data, we see just looking at number of psychiatric care beds, there are significant differences. So you've got on one end Japan, which has 1.5 beds nearly per 500 people, 1.5 psychiatric beds that is, right down to countries like Italy, where it's 10 per 100,000. Same is true of the average length of stay for mental and behavioral disorders. In Korea, it's nearly 4 months, whereas in Norway, it's just over 3 days. There are big differences in the way that the workforce is organized, in the way that resources are invested in the professionals who deliver care. There are big differences in the number of psychiatrists, nurses and psychologists, and other people in the workforce which we weren't able to collect data on. But there's differences in both the absolute number and also in the distribution across the different workforce categories. But there are also some similarities, the most striking of which is the strong trend towards the institutionalization and the reduction in mental health beds, which we saw in all OECD countries with the exception of 2. One of those is Korea, which is the light blue line on the bottom. And Korea has seen a completely contrary trend, and they've seen mental health beds increasing. The other one is Germany, who's seen a slight increase over the last few years. It's not an increase, which I understand. If anyone has any ideas, I'm keen to hear them. But the strong trend is towards reducing beds. This shows the last 20 years, but in many countries that's a trend you can see in the last 50 years, really. Another really clear similarity was the importance of primary care providers. Here you've got general practitioners, but not all OECD countries have general practitioners per se. But the real importance of primary care providers at the front line of mental health care. So here you see the type of provider consulted for mental health problems. And we'd add to that that they are normally the first provider consulted for mental health problems. Another similarity is the significant gaps in between need for mental health care and treatment for mental health care. This is a figure produced by our colleagues in the employment division at the OECD, and it shows the number of people in specialist treatment by the severity of their disorder. And what you can see is for the average 21 countries that they were able to collect data for, I have to find the right place, even for the most severe disorders, 25% of people who were judged to need treatment were in specialist treatment. That's not to say they weren't in some kind of treatment. This figure excludes treatment, for example, by general practitioners or by social workers. But we would say that even in countries like the UK, where general practitioners are playing an increasingly important role in treating and managing severe mental disorders, that's quite a low toe there. You know, even for moderate disorders, it's incredibly low, but even for severe in the UK, it's below 20%. Other similarities, just briefly, in other areas of the health system, there have been significant evolutions and experimentations in the way that care is paid for. So, for example, trying to change the way that care is paid for to promote quality rather than volume. That's not been the case in mental health systems. Most mental health systems are still funded through global budgets and per diems, which has some complications associated with driving up length of stay, for example, in Korea and Japan. We think that there is overwhelmingly poor data on most aspects of the mental health system in most countries. That a large proportion of the health budget, as in a percentage of the health budget, is going towards mental health care in most countries, but that large proportion, about 10% on average, is not necessarily enough to deal with compensating for some of the high indirect costs of mental health, and also the high population burden that we see in all countries. National and international estimates vary a little bit, but the figure we work on is 1 in 5 people at any one time will be experiencing a mental disorder, and 1 in 2 in their lifetime. This is a heavy microphone. So having had my microphone break, I've already really started to draw out some of the things that we've identified as problems. So some of the similarities could definitely be seen as good things. We think that the primary care similarity is a very interesting one, and one that we'll come back to. But some of the similarities and differences point to some of the problems that we clearly established. So in this section, I want to establish some of those problems and really the costs a little bit more clearly. The first one is, I've already alluded to, which is the big treatment gaps. And this is not just the gap between need and provision, which I've already pointed out, and I'm sure many of the people working in the mental health field are already fully aware of these gaps. But it's also a gap between need and available appropriate treatment. Now, that might be available in appropriate treatment in terms of the scale of treatment, the degree of treatment, the intensity of the treatment, but it can also be to do with the completeness of the treatment, having enough of the right people involved in the treatment. And one of the ways, I've lost it again, one of the ways we see that very clearly is when we look at excess mortality. So we saw across countries, based on national estimates, that people with severe mental illnesses died up to 20 years earlier than the general population. And when we did a collection of this information in 2013 at the OECD, it's a collection that we're doing again this year, and we'll present again this year, where we tried to compare mortality for individuals diagnosed with schizophrenia and bipolar with mortality for the general population. What we saw was really significant differences. So people with schizophrenia have a mortality ratio which is 3, 4, 8 times higher than the general population. And for us, this isn't just because of a higher rate of suicide amongst people with mental illness, but it's also because of gaps in care. And it's because of the gaps in the physical care for people with mental ill health. So what we saw when we looked and talked to countries was that people with severe mental disorders like schizophrenia and like bipolar were much more likely to die than the general population from chronic somatic disorders like cardiovascular disease, diabetes, and cancer. For us, that's a treatment gap as well. The next real point is about the high costs. I've already alluded to some of these, but to really break it down, the total economic cost of mental illness based on the countries which we're able to report, we've estimated at about 4% of GDP. So you've got countries which are spending 10% of their health budget on mental illness, which compared to other disorder areas is maybe high, but you've also got countries losing 4% of their GDP on costs related to mental illness. Those might be costs related to investment in care for people. That's a good cost, but it's also to do with bad costs. So additional costs elsewhere in the health system. Somebody with depression and diabetes, their diabetes is much, much more expensive to treat than somebody who has their depression appropriately managed and their diabetes managed alongside that. People with mental illnesses, even mild experiences of depression or anxiety, for example, are much more likely to be unemployed and much more likely to be not as fully employed as they should be. These are some of the estimates of direct and indirect costs. And I think one of the things that's most striking when we look at these is how consistently the indirect costs are higher or almost equal to the direct costs. Our colleagues in the employment division at the OECD have done a long series of work on the impacts of mental illness on employment and performance in the labour market. And what they found was, incontrovertibly, people with a mental disorder, even a mild or a moderate disorder, which is an episodic disorder, for example, are less effective at work when they're at work. They're more likely to be absent from work, so they're more likely to take days off sick, and they're more likely to be out of work completely. People with mild and moderate mental illnesses are 2 to 3 times more likely to be unemployed, and people with severe mental illnesses are 6 to 7 times more likely to be unemployed. And the third thing I've put up, I suppose, partly as a cost, but as a major challenge, and really for us a blockage to more progress, is the big gaps in information in mental health systems. So a lot of the time we don't know what's going on in systems. So this means policymakers, people like me, who are trying to compare the systems and give you a sense of what's going on, policymakers in countries, but also people working within systems, don't necessarily know what's happening in their system. When we started this project, there was a sense that we needed that really gave a better sense of what was happening in mental health systems. So there was a sense from the committee and from the OECD Secretariat that the number of psychiatric beds wasn't a very accurate indicator of what was really happening in mental health systems. So we set about trying to do that. And we asked all of the OECD countries what indicators they might be able to report on. This isn't which of the indicators which will be internationally comparable. This is which of these things could you get your hands on in your country. We sent a list of about 35 indicators around, and these are the 5 which had the most positive results from countries. So you've got 20 for readmission rates, which we decided had its own problems. But for the others, we have 6, 5, 3, 6. So this is the state of the information that is available. If people want to find out more about what's going on in the country, it's incredibly difficult to get hold of that information. So we came up with some recommendations, and as you would expect, these recommend.
May I ask you a quick question? You're talking about the committee and the secretariat. Who is part of this committee that is giving you, that you're reporting to this committee? Who's in?
The committee is made up, the question was, for people who didn't hear, what's the OECD committee and what's the OECD secretariat, roughly? The OECD committee is made up of delegates from all of the OECD member countries. So the people who decide what we work on and to whom we report back are delegates from all of the OECD member countries. So I can't off the top of my head tell you who the French delegate is, but
right, no, it's just
yeah. So that we're reporting back to representatives of the ministries of health, usually of our member countries, and the secretariat is the people they've employed to do their work. So this is what we reported back to the committee. We thought that there were 3 main things that OECD countries needed to do to make mental health count. So I don't know if the name translates into French, but in English it's a play on the word count. Count to mean add up, and count to mean be important. So the things that need to be done to make mental health care make financial sense for societies, because a mentally healthy society is an economically productive society, and also to make mental health care have the importance that it deserves, and to allow OECD populations to access mental health care of a quality that they deserve. The first thing is to measure mental health. The second is to increase evidence-based services and strengthen primary care. And the third is to align incentives and organization to improve outcomes. I'll go through them briefly. So firstly, to measure mental health, we think there's a need to systematically identify people who need care. This can be done in various different ways, but a number of countries don't even have, for example, a periodic epidemiological survey, so they have very limited sense of what the burden of disease is in their country and what the level of need is. We think it's absolutely not enough to make a list of people in touch with mental health services. It's a good thing to have, but in terms of identifying need, given that we know that people with mental illnesses systematically don't seek help, you need another way of identifying people as well. We think there's need for a better understanding of the costs of mental illness. Ideally, this would mean a better understanding of the direct and indirect costs of mental illness. But we could start with a better understanding of the direct spending on mental health. Many countries really struggle to say where their budgets are going, to know where their mental health budgets, which sectors they're going to, which services they're funding, which areas they're being directed towards. And in a climate where health budgets are undergoing increasing pressure, it's really important to be able to say, this bit of money is going into this service, and this service is doing a great job. Mental health systems are increasingly having to justify the way that they're spending the money. And if they can't say where they're spending the money, the justification is a lot more difficult to do. And related to that, we think that there's a need to improve reporting and information that's available on quality and outcomes of services and care. Now, this isn't to immediately link payment, for example, to outcomes and quality, but it's to have a better understanding of what the services that are in place are delivering. Are they delivering improvement? Are they delivering people who are able to lead more successful lives? And it's not just for the most acute services, it's for all the services all the way through. And in other areas of healthcare, there's been I suppose, a more successful attempt to do this. In mental health care, the impression that we have is it's very tricky because of the very heterogeneous nature of a lot of the disorders. But it doesn't mean it's impossible, and it doesn't mean it's not desirable. A number of countries have been experimenting with outcome frameworks where they trace the functionality of the patient and their self-perceived experience of the care and their treatment, the severity of their symptoms. And it doesn't mean that every service has to deliver for every patient a fantastic improvement. We know that that's not realistic, but it's about understanding the relationship between the system and the service and the individual. The next thing we think is important to do is increase evidence-based services and strengthen primary care. For this, we're mostly saying about mild and moderate disorders. We think that there's been a gap in OECD countries in the attention that's paid to mild and moderate disorders. So the strong narrative in many OECD countries has been, how do we do deinstitutionalization? How do we deal with the consequences of deinstitutionalization? Is deinstitutionalization the right thing? These are important questions, but there's also a big population of people who are suffering from disorders that would never put them in contact with a psychiatric hospital, that would maybe never put them in contact with the most specialized mental health professionals, but who are experiencing mental disorder and would significantly benefit from appropriate treatment. These are sort of a grouping of disorders we call mild and moderate, so disorders, symptoms, whatever. And we think for them there is good evidence that some interventions and therapies can be effective. For example, psychological behavioral therapies, talking therapies, either with or without pharmacological therapies. This is going back to one of the first figures that I showed about the role of primary care practitioners and GPs. And given that we know that the primary care practitioners and GPs are overwhelmingly the most significant professionals consulted for mental health problems, we think there's a need to make sure that GPs and primary care practitioners have the skills, the expertise, the resources, and the professional backup in order to do this job effectively. So GPs, in the studies that we reviewed and the GPs that we talked to, said that they didn't always have the skills or the capacity to correctly identify mental disorders when they saw them, and that they didn't also always have the resources and the time to treat mental disorders, even if that was a mental disorder that they should be expected to treat. So the competency and the capacity is about things like training and education, making sure that mental health has a really core part of primary care training. But it's also about making sure that there are support networks for GPs, that they can get in touch with specialist mental health professionals, that they can have formally or informally networks which allow them to upskill in order to respond to the needs of their patients. And directly related to that, we think that there's a coordinating role for primary care to play. In many countries where care is increasingly being shifted to the community, the centrality of the hospital is no longer there. So patients have diverse needs in the community. They're in touch with a number of different services, with mental health services, with social care services, and hopefully with physical healthcare services. And we think there's potential for the GP to play a role in coordinating some of this. This is already happening in some countries. And we say, as part of this, it's vitally important that enough attention is paid to the physical health needs of people with mental illnesses, especially with severe mental illnesses. And the last one is really about making sure that systems are consistently turned towards delivering good outcomes. I would hope, talking to you, you would say, well, yeah, of course, we're thinking about good outcomes. But it's not always obvious, and it's not always obvious for policymakers, that good, better outcomes are what systems are driving towards. It's not just about containment, it's not just about making sure you have the most neatly organized system. It's about making sure your system is working as a whole to deliver improvement and high quality care. We think part of that, which is perhaps missing at the moment, is seeing the system as a holistic whole and making sure that there are good networks and linking up different parts of the system, both within the mental health system and between the mental health system and the rest of the health system and the social care system and the education system and the employment system, to make sure that all those bits together are driving for better outcomes. I'll finish on this slide, and it puts back up the main points that I've touched on. And I've put at the top, what is the state of mental health in France, which is, I suppose, saying, this is what we saw when we looked at all 34 OECD countries. What do you think about this for France? Is this accurate? Is this missing the point? Is this what you'd expect to hear? Is some of it surprising? I would be very interested to hear your opinions, your criticism, your feedback, your questions. I'll flick back to this slide, but before I finish, this is all of our information. Everything we publish is online. You can follow us on Twitter. And you can write to me, my email address is there, if you want to continue the conversation. Thanks very much.